This is the second of three talks this lecture, this semester. I'd just like to welcome everybody here. For those of you who aren't familiar, the center is devoted to looking at emerging and developing topics in emergency response, particularly those that straddle more than one traditional discipline, police, fire, EMS. We're very pleased today to have Len Garis with us. Len is affiliated faculty with the center. We've had a relationship with him that goes back almost to the center's founding, and certainly I've had a relationship, an academic relationship with Len going back well before that. Len was here, for those of you who are keeping score, he was here back in 2015, just after Hurricane Sandy. Oh no, that wasn't the evidence-based talk, was it? Was it? Yep. Okay, he was here just after Hurricane Sandy and spoke about evidence-based practice, and he's got a copy of that book, which is now in its second edition, and it's directed toward, he has three versions for police, fire, and general government. Today, he's here to talk about the problem of opioid and fentanyl and their abuse and the consequences which manifest themselves for public safety as overdose calls. Canada has leadership in a lot of areas, and regrettably this is an area where I think we have a lot to learn from Canada's negative experience. And I know for those of us in the industry, this is a huge problem that we have really not confronted. And if you look ahead to what's going on, you can see that it's, unless we act, it's just going to get worse and worse. And the consequences, as we all know, are really staggering. So this talk, I think, is particularly noteworthy because it has, as Len has always been, and I like to call him the most progressive fire chief in North America, but I think I have to revise that title, and I'm emerging now. I think he's overtaking a lot of the police leaders. But in terms of really looking at data-driven problem solving and evidence-based practice in real life and really applied, this is a really beyond cutting-edge set of data and set of projects. And I think it only could have come out of the long experience that Surrey Fire Service has had in terms of leading these kinds of initiatives and kind of the unique ecosystem of academics and practitioners and the resources, and most important, I think, the executive level focus to really enable this level of applied analysis toward a real emerging public safety, or actually it's not emerging, it's emerged public safety crisis. So with that, I'm really pleased today to welcome Len Garis, is again fire chief from the city of Surrey, British Columbia, which he will tell you about. Also on faculty of the University of the Fraser Valley. Without further delay, Len, so welcome to New York.
Thank you.
Okay.
I'm really fortunate to work in a city where my directive is very simple. The mayor's office and the city council, for its department heads and public safety, it's very simple. We want a safe city. And under that guise, we can move into areas that we traditionally don't go to. And certainly this issue with fentanyl crisis and the overdose crisis has led us to where we are today for some of the work that we're doing. I'm not doing this by myself. We have obviously our chief of police, we have our public health officials, public safety director. There's quite a number of people that are working within the scope of this work, and we're exploring everything that is humanly possible in order to try and manage this problem that we have in the city. So I'm going to pretty much start by giving you a sense of where we are. And of course, we couldn't get much further away from each other in terms of where Vancouver, British Columbia is and where New York is. And British Columbia is woefully small compared to New York City, of course. We're about half the size, I would think, about 4.6 million people, in a population of Canada, which is 35 million people. And once again, about 10% of the rest of the United States. I want to talk a little bit about the problem and the origin, understanding the scope of the issues, understanding the person that we're dealing with in terms of the opiate crisis, some technology that we've been experimenting with in terms of real-time overdose data used to assist our first responders, We're going to be looking at a new initiative where we're going to be sampling wastewater, and we're going to be looking at wastewater epidemiology, and we're going to be calculating the rates of consumption in the neighborhoods backwards, so we can maybe become more precise on where we're going to be interacting with and messaging within the opioid crisis. And there's been some work done on that in Europe and also in Eastern Canada, and we believe it'll be very helpful in understanding what the dark side of the overdose or the drug use crisis is in British Columbia or in our city, because we just don't know. And we're going to talk a little bit about community action, safe injection, recovery homes, and construction workers who seem to be overrepresented in the group. And I know that the state of New York, the city of New York, has been talking about safe injection and what that might bring you, and we have a bit of experience with that. So to start with, British Columbia is, we just, at the end of December, and this was Stats Canada's data that they extracted at the end of 2017 or 16, and we were 20 per 100,000 people that were dying from overdose. At the end of 2017, that was 29.9, 29.6 per 100,000, and it's basically growing at a rapid pace. That number actually translates into about 1,422 people that died, 43% increase over 2017, over 2016. 51% of those dying were between the ages of 30 and 49, and 82% were male. And that's kind of where our starting point of what we're dealing with in our province and in our city. Right now, in terms of the major causes of unnatural death, overdoses outstrips suicide, motor vehicle accidents, and homicide combined. And so it's on a very steepward curve, and it's something that we're very, very concerned about in our province. And I know there's pockets around the United States, and I think you're starting to experience some of that as well. So a little bit about Vancouver. British Columbia is a population of 670,000. It's a beautiful city near the ocean. Surrey is inland a little ways, and you can see Vancouver off into the distance and Surrey in the forefront there, which is growing at a population of about 570. We're about the 9th largest city in Canada, and at 570,000, so I know it seems very, very small compared to the city of New York for sure. In crisis is basically fentanyl. Fentanyl represents about 85% of the drug overdoses that we're dealing with. And we found carfentanil, we found all various different iterations of the fentanyl product or fentanyl analogs in the drugs or the people that have died or overdoses. It's very difficult. Our coroner's office has not been able to keep up with the toxicology. We've really been difficult because this has just sort of jumped on us. A little bit about fentanyl. Probably don't need to give you a lesson on that, but just so it can be found in pill, powder, liquid, lozenge, or patch forms, and its effects are euphoria, relaxation, controls pains and emotions. Death is usually due to respiratory depression or cardiac arrest, and it's physiologically and psychologically addictive. Fentanyl is about 50 times stronger than heroin. It's also so potent that about 2 grains of salt is lethal to an adult. And so it's very, very powerful. First synthesized in the 60s by Janssen Pharmaceuticals, fentanyl was initially used as an anesthetic, and then it was used for cancer pain medication as well. And it's found itself into the illicit markets, of course, right? And so basically done by Johnson & Johnson, and of course now we're finding this into the illicit markets, right? So we're finding our cooks, and the biggest challenge is trying to find out where this is coming from and trying to head it off. They believe that the Mexican cartel's illicit drug labs started mixing fentanyl with heroin, and that's where it began. It found its way into the system. So where is it coming from? Well, a lot of people believe that the vast market from Asia is where it's coming from. there's little regulation to import along with its ingredients. However, I have to say that last spring, I was in Shandong province in China. Shandong province is a population of about 100 million people. And I was at the police college there, and I spent 2 days there lecturing on evidence-based decision-making. And I talked to some of the top drug officials, and in China, of course, things are quite a bit different there. But what I was really clear about is the Canadian and the U.S. Law enforcement believe that China is a supplier, and I'm not disputing that, but I just find it strange that the Chinese law officials cannot find fentanyl in their drug-addicted people. However, in a population of 100 million people, there's 100,000 drug addicts. So that's kind of it's not very predominant. And the drug of choice in China is methamphetamine. But I also went down to Kunming in the Yunnan province, and I lectured there as well, and I've got the same story. It wasn't prevalent in terms of finding drugs in the market. And so I'm really worried about where the source is coming from and what we might be doing to try and locate that. And the interesting thing there, of course, and this is China, of course, but those drug addicts will actually be tested, and they will have mandatory treatment. And so they will know what they're using. So at least that's a piece of evidence, but it is concerning because I'm not so sure that I'm confident that that's where it's coming from, or if it is, under what set of circumstances. But the simple economics is a kilo of heroin is $80,000 Canadian, rough, plus or minus. A kilo of fentanyl is $8,000 Canadian. A kilo of fentanyl is equivalent to 50 kilos of heroin, or about $4 million Canadian. So there's a huge profit margin in that. And what we're thinking is that once again we'll talk a little bit about that a little later. But in the market of pain medication, there's a large cohort, we believe, of construction workers or individuals that are dealing with pain management, and we're likely prescribed opioids or opiate-like type medication in order to manage their pain over the years. And when the College of Pharmacists and the College of Physicians started to become concerned about their patients that are becoming addicted from the opiates, they started to pull back on those prescriptions. And pulling back on those prescriptions opened up a market for the illicit market, and so we've seen much more. And we're seeing overdoses, and you'll see geographically in the city in places where we would never expect to see them. They're in people's homes, they're in good families, they're in all sorts of other places that we never expected it. So the question might be was that addiction or those drug use, was it there anyways? And what we're seeing now is that fentanyl, which is too strong, or stronger than what the individual realized, and now we're starting to see them overdose, and they're starting to present themselves in the population as an overdose. And we're starting to see that in concentration. So illicit fentanyl, drug traffickers are using fentanyl products as a cutting agent in heroin and in other ingredients that imitation oxy pills, commonly sold as oxy 80s. Why fentanyl? Well, wherever it's coming from, if it's from China or from Southeast Asia or wherever it's coming from, very small amounts can come through the Canada Post, and it's very easy just to throw it in the mail. Apparently, you can buy it over the internet, and you can send a couple of grams or a thimbleful, which is plenty to make lots of money and to cut other drugs with it. And part of the problem is that the drug makers haven't figured out what the dosage is yet in order to manage that, and they're actually killing off some of their clients. I hate to say that, but that's what it appears to be. But certainly it can show up in the mail. It's very difficult to check every piece of mail, figure out where it's coming from. And as I said, counterfeit OxyContin seems to be the drug of choice. We're finding few deposits where it's been secondarily being manufactured with pill presses. And this seems to be the issue, is the hot spots that are associated with when they mix the drugs. If you see a few specks or too many specks, too much into a particular drug, the individual has not got the ability to withstand it. If he's a heroin user, he's certainly used to the opiates. But if he's a crack cocaine addict or something, some individual like that, they're not used to this in their system, and it hits them pretty hard. I'll talk a little bit later about this, but we had an incident in a neighborhood or a municipality just adjacent to us, and it was 8 young individuals that made a purchase of some party drugs that had fentanyl in them. And they all went their separate ways in order to go wherever they were doing, but they made the buy together as a group, and away they go, and they started overdosing. Fortunately, they reversed a couple, the first 2, and they were able to tell them that their friends had actually purchased this as well, so there was this huge hunt to try and locate these individuals. And out of the 8, 2 died, and 6 were actually recovered, right? So that really woke us up to say that this is a huge concern for us, and we're going to likely see more of it, which we did. So carfentanil and the fentanyl analogs are just like massively powerful. Carfentanil can be 10,000 times greater than morphine in terms of its strength. So those individuals you saw before with the glasses on and the coat and the little beaker, they're the ones that are mixing those drugs. And so if there's, what we're telling people, believe it or not, is individuals that are buying drugs, know your dealer, make sure that you've used it before, make sure you're using with somebody in your presence, make sure you have naloxone with you. All of that messaging is going with it, because to try and control it and keep these people from dying. The relative strength is just phenomenal. We're talking about sedating an elephant with a few grains of this material as opposed to an individual and who's getting high. And apparently over time, what I'm told is the drug addicts are actually prefer fentanyl over heroin now. And it's a better high, and it's something that they like, and they're actually craving for it. So it's just the mixture. So, and the party scene, of course, we're seeing it, as I just mentioned to you, we're seeing it in the party scene now. Individuals are buying it. It's being laced with, as I said, crack cocaine, but also ecstasy and other drugs like that as well in order to give that additional high. So basically it's in everything and everything that you can think of. We've heard, anyways, from the coroner and from police services. So, of course, now it's what we're trying people is the harm reduction route. We're communicating, carry a naloxone kit. Right now, if you're in British Columbia, you can go into the pharmacy and you can ask for naloxone and they'll give you a kit, an injectable, with vanishing point needles. And it's easy to get. Naloxone is everywhere. We're asking people to, if they're using it home or on the street, naloxone is virtually everywhere. And that started probably at the beginning, the first half of 2016. In the very first part of 2016, our fire services weren't equipped with naloxone. BLS and ALS was, but with the ambulance service, it's ramped up its procedures, the response times or the wait times for firefighters on the scene with these patients was stretching, sometimes 20 or 30 minutes without the ability to reverse the issue, just trying to maintain their respiratory or cardiac rhythms in order for them to get somebody to get there so they could inject them with naloxone. Now it's virtually everywhere, and everybody has it. So call 911, stop the overdose. This is a communication that's happening. You've probably seen this video somewhere before, or this picture. It's been quite popular, and people are using drugs recreationally and are overdosing, and where they basically weren't before. And there's a lot of tragedies. There's, it's not germane to just basically street entrenched people. It's everywhere. It's simply everywhere, and you'll note that when I show you the city. So this isn't a common scene, but certainly we have areas in the city where we have large concentrations of homeless people living in tents and are highly drug addicted, and it's becoming their own kind of communities, right? So knowing the signs, carrying a naloxone kit, dial 911, stop the overdose. There is a stigma with police. Police are not responding to these calls. Fire and paramedics are because of the concern about the possession of the drugs and those types of things. And there is also a Good Samaritan Act that has been reinforced, so individuals will intervene. Police officers are not enforcing, they're not taking away drugs from individuals that have them on their person for personal use, and we're trying to change that stigma so they will call us. Police officers are using nasal spray, naloxone, as I said, firefighters, injectable, and so are the paramedics, but certainly health nurses and street people or street workers, everybody's carrying naloxone. So basically what you can expect is respiratory distress, nervous system, depression, drowsiness, reduced level of consciousness, dizziness, nausea, limp body or pinpoint pupils, the symptoms. These posters, we're finding them everywhere, like places that you would never expect, like in the downtown core, in places like McDonald's washrooms where drug addicts are using. And so we're trying to socialize McDonald's, whereas the children's place, to bring posters into their washrooms like this, just so that we can kind of message. So we're having lots of social challenges with trying to get people's head around it and make them understand that we're trying to communicate with these people to try to understand that there's another way, right? So we're introducing replacement therapy for like Suboxone and other ideas. They're even talking about potentially putting Suboxone and registering somebody with a thumbprint, putting it into a machine so he can dispense it himself. And they're looking at ways where individuals can actually self-dispense another drug or another product so that it's not so hard on it. And that's, we're kind of going right outside the box. Once again, naloxone is simply everywhere. Everybody carries it. As we probably know in this room, it's reversing the overdose, and it's basically it disconnects the receptor on the brain, and it gives them a 60 to a 90-minute break. And so they can't, hopefully they don't reuse, but I can tell you that some of the stress load and the issues with our firefighters, our first responders, they're seeing sometimes the same patient 5 or 6 times a day that are overdosing and bringing them back. And that's starting to wear on those individuals. So now we're starting looking at strategies, both in the city of Vancouver and Surrey, moving our first responders around to give them a relief from that. And as you know, first responders are highly aggressive. They don't want to be moved. They want to be part of it. But they also are very concerned about the lack of society. They're in this sort of warfare, they believe, in this situation. They want to know what we're doing about it. And that goes back to what the mayor had told us and said, I want a safe city, and that allowed us and gave us license to start drilling into some of the more detailed, deeper dives into the individuals and into the problem, which I'll talk about. So we trained all of our firefighters in February of 2016 so that they could administer naloxone. We're using vanishing point needles. The overdose by month in the province of British Columbia, and you'll notice in the far right-hand corner that 1,422 is where we ended up at the end of last year. But the growth range in terms of the monthly average, basically 118.5 in the province. And how it's grown since 2007. Now, the breakdown for gender, of course, males are highly overrepresented in the group that are dying from an overdose. Females are certainly they're not immune to that. The age group between 19 and 59 seem to be the core of the age group that are using, so it's right across the spectrum. And in terms of townships, the city of Vancouver, of course, is a top runner at 358, about 1 a day. City of Surrey, right behind them at 174 deaths. And then the city of Victoria, which is the capital city in British Columbia, at 91, for a total of 422. See as it cascades down. And that's what it looks like in terms of the rate and the trajectory that basically we're on. And so far this year, for January and February, we're looking at about 20 a month, 25 a month of deaths. So we're starting to climb and ramp up fairly quickly. So in terms of overdoses or calls for service, these aren't deaths. In the city of Surrey and Vancouver, we broke these out and looked at the last 3 years. In 2015, in terms of Surrey, was 1,606, and at the end of 2017, it was 2,801. Not quite double, but Vancouver certainly was at 2,500, and then going to 46, and then 6,100 overdoses calls for service. and it's just like a massive, and these guys are in the areas where they're busy, they're running from pillar to post day to day, along with the paramedics, of course, and there are individuals that are overdosing multiple times a day. So that's the city of Surrey, and as you can see, for 2017, what you're looking at is obviously the hotspot area, which is the inset on the left, which is kernel density, which is basically to show where the concentration of the overdoses are. The pink dots are where the overdoses are occurring in the city, and the blue stars are where naloxone was delivered. No, that was either by us or by a paramedic, because we're a layered response, so we're attending with the paramedics as well. And that's kind of what it looks like. So it's basically, as I said before, it's virtually everywhere. That's the inset, and there's 2 safe injection sites within that area, and I'll talk a little bit about those later on, and where those are occurring and what's happened. And this is our 135A Street, and this is where that concentration is, and these are drug-entrenched people. They're homeless, living on the street, living in tents. We have about 220 tents, and about probably close to 300 people that are living in that area. We went through you probably say, well, why? Well, before us, there was a camp in Victoria, and there was a camp, 2 camps in Vancouver. And the Supreme Court of British Columbia said, if you don't have an alternative place to take them, you're not going to be successful with an injunction to displace them off your city property. Because you've got to go somewhere. And so that's what we're struggling with. So we've been managing this situation for about 18 months. British Columbia Housing now has given us workforce housing and the ability for us to move some of these people into a better set of circumstances to the time that we have to build social housing. And social housing we will build. But it's moving very slowly. The neighborhood that concentrates around is a business district. It's an older business district, and businesses are leaving in those areas. It's very depressed. Property crimes are incredibly high, and it's not a safe place to be. These individuals, 2 years ago, were quite amenable. A lot of people, volunteers were going there. They will help feed them and provide them with blankets, those types of things, and humanitarian situations. Now, if you're a uniformed police officer or a uniformed firefighter, you better be going with lots of support, because there's lots of stress that's built up into this situation here. And they know that they're going to be moved into housing, and there's a large portion of them that don't appreciate that. So I suspect that there's going to be a lot of finesse that's required in order to help transition these people, because it's a society, if you will. It's a neighborhood. It's their social norms, and they're their norms, and they're not our norms. And so to impose those, there's going to be some conflict, and what the right norm is, I'm not sure what that is, but we're trying to help these people, but they don't necessarily like the help that we're going to provide them. So it's going to be an interesting transition, and that will take place over the next 6 months. And workforce housing will be available for them in another 2 months. So we'll be making this transition. So my message to you, if you're with a local government or law enforcement or whatever, is we need to make sure that as these small camps develop, we find them housing, we find places for them. Unless you want it to grow and grow exponentially, which it has for us. I'm not saying it's a good thing, I'm not saying it's a bad thing, but it's not the right thing. Right? We need to help these people in their disparate ways, and that's the way that we're moving. It's been very difficult for us. So, open-air drug use is very common. Police officers, that you saw on the slide before that, they will not intervene with that. It's harm reduction. It's trying to manage the situation, and that's very, very common. Wintertime has been bad there. Individuals will bring in propane heaters. We've had explosions. We had individuals that are cooking their drugs or basically rendering hash oil, and we've had explosions. We've had lots of concerns that are associated with the fire issues associated with that. But on one hand is, it's below zero, and you're taking away their heating source in a tent or an environment that shouldn't have an open flame. And it's very difficult trying to manage all of these issues together, right? So we went out and we bought them blankets, we bought them hot water bottles during the real cold snap. We bought them solar lamps so they don't use tea candles, and we've tried to help to offset some of the risks in order to manage that. And the Professional Firefighters Union and charitable organizations, everybody's chipped in to try and find these alternate ways so that we can make it safer for these people. So, City of Vancouver, very much the same, but a little bit different. You'll notice that their concentration of overdoses are probably more around the downtown core, and the concentration that you're seeing, the inset, is where their downtown east side is. It's very famous for that. It's had a safe injection site for about 10 or 15 years. And that's would be the concentration of that. And you can see that this is the downtown business area of the city. Overdoses are taking place everywhere.
Chief, once again, the stars represent?
Where naloxone has been delivered.
Okay, and the dots?
The dots where an actual overdose has occurred. But not necessarily naloxone was delivered at every one. So downtown east side is very similar to Surrey. Tent cities along the sidewalks, in parks. They've occupied various different parks. They've had to get injunctions, but they had to find housing in order for the judge to support the change or the displacement into permanent housing. We know the housing's important. We know that, and to try and find them places, and it just seemed to be there are more people than there is the ability for us to build housing, social housing for them. And it's becoming very challenging. So, of course, people are on the sidewalks. I haven't seen that in New York, but I've only been around this area here, so I don't know what that looks like. This is what the average number of overdoses between the two fire departments, Surrey and Vancouver, look like for 2015. These aren't deaths. These are calls for service for overdoses. And you'll notice in the end of 2016, Vancouver was averaging 25.6 overdoses a day, almost in the same places. And then Surrey just above it at 8.6. We topped out at about 10. And then we actually went back to council, and we hired another two-person med engine rescue unit in order to staff it, because we just started running out of the ability to go from one place to another. We were just going nonstop. The units weren't returning to the station. We had no downtime. And you'll see that that's sort of tapering off, but the deaths haven't. No, I think that might be the overdoses that we're not going to are probably being serviced by individuals that people are with. Everybody's equipped with naloxone, which is a good thing. We probably would see much higher death rates if we wouldn't have been equipped with that. So average response times is not a criticism, but fire services are generally there quicker, and this was our argument for our reason for becoming equipped with naloxone. These are average response times. The blue line is the fire response, and the red line is the ambulance response. And of course, Vancouver and Surrey very similar. There is a distance there, and nobody's trying to compete with each other. We're just trying to get to those individuals and see if we can bring them back quicker. Overdose awareness and harm reduction is everywhere. Our fire crews, our ambulance paramedics are all carrying information about naloxone and about getting a kit, about the fentanyl issue, about how to prevent an overdose, learn how to respond to an overdose, and we're leaving communication materials everywhere we go. And as I haven't mentioned right now, is that about 9% of the individuals that die are in that kernel density area, and about 28% of the overdoses. The issue is everywhere else, mostly in people's homes. About 85 to 90% of the people that die are dying in their homes. Families that don't even know that their spouses or their son or their father, their uncle is using. So we're leaving that information, especially to survive, about what this whole issue is about, because it's been done in secrecy. It's those people that are using drugs that we may not have seen before in society, right? Now we're seeing it because fentanyl is causing the overdoses. So lots of online materials about talking to kids, about open conversations about the drug issues, and trying to tell people that this is happening in your community and about the concentration of that. We have this massive big organization that has been built by the provincial government with the Minister of Public Safety and the Minister of Health chairing these two groups with an overdose task force. Now this started, I'm reminding you, this started in July of 28, 2016. And now we're in March of 2018. And we're still seeing the trajectories going through the roof in terms of the deaths that are associated with this. The overdoses seem to be coming down. But all these various groups are working towards trying to understand this problem. So in the 2 years, and what you're looking at here is basically 2 years of overdoses in the city of Surrey. And what we're focusing on is where those overdoses occurred indoors. And you'll see that's characterized by a black house. Outdoors by a green. And then yellow that's in the service area, what we call the inset area that has all the safe injection. So it gives you an idea of the concentration of where these overdoses are occurring. We're becoming more than curious, but focused on how do we get in front of this? And I'll talk a little bit about that. One of the things that we discovered through that scenario that I mentioned to you, where these young children or adults had purchased fentanyl or drugs and left and started overdosing, we had a weekend where we had 17 overdoses in a very short period of time. And we didn't realize it until it was probably almost over. But we were just basically, resources were running pillar to post. And people were overdosing that weren't normally on the street. They're in bars, they're in other places, and it appeared that they had purchased crack cocaine, and it was laced with fentanyl, and they were overdosing. And we ran very close to out of resources, moving things around, trying to catch those calls and trying to suddenly staff up with other units. And we came up with this idea that we have basically a software tool, it's a BI tool, that allows us to monitor real-time calls coming in, and we can segregate those out, and we can write a business rule around that. So it's a business intelligence tool that we developed for crowdsourcing to identify the time, location, and details of overdose incidents happening in clusters within the proximity of each other. This is an application or a business tool that's based on fire incident data that has real-time, data-driven response to addressing the opioid crisis. The business rule that we developed was clusters of 4 incidents occurring in a 1 kilometer area over a 4-hour period. And we did that because that is the focus of generally how people that are on the ground will forage, either from service area to get what they need, their drugs, back to the areas that are supporting them, the recovery homes, or not the recovery homes, but the shelters. And that's usually the area in which it works. It also calculates the rate of twice the daily rate, if that occurs. And what it does is it captures that data, pastes it on a map and an email, and it sends it to our operational battalion chiefs or whoever, so that they're aware that this is emerging. They can see real time. There's an uptake on the number of overdoses. And then we can start adjusting and moving our resources if necessary. So that's kind of what the software, the application looks like. This is one incident, and it pastes it on the map. And then there's 2 incidents that occurs, and it shows you where they are in proximity. And then this is 7 incidents, or twice the daily rate, and it pastes it on the map, and it emails it to our chief officers, whoever is making decisions on deployment. So it brings their attention to a real-time monitoring of what's going on. And that's what he would be emailed, or she would be emailed, and she would have that on their smartphone. So they could instantly have a look and say, okay, well, what are our other resources look like? What's the availability of everybody else? Do we need to react to this or not? The other thing that we did is we signed a privacy sharing agreement with Fraser Health, because Fraser Health had a lot of volunteers and individuals that are on the street that are managing street entrenched people, trying to provide them with services. We give them that information too, real time. So they can start surging into those areas and maybe start suggesting to their clients and people that they know there's some bad drugs out there. You want to be careful. We've been told that individuals that are in, when one of these alerts has gone out, there will be an individual that will be injecting themselves with heroin, and at the same time they will have a needle ready and already started in themselves with fentanyl, or sorry, with naloxone. So just in case they overdose, that somebody can actually depress it. It seems kind of stark to me. So the use of this application is a public health surveillance tool. We're also waiting to sign an agreement with the police under our privacy agreement, because they too carry fentanyl, or fentanyl naloxone, and they have the ability to surge into those areas as well. Maybe they'll spot a drug dealer, and maybe they'll be able to apprehend somebody. So all of our first responders are basically going to be part of this initiative, and it gives us as close to real time to get to those individuals. So with the foresight, emergency services will be faster, potential victims will be provided with support, educational material when there's a surge of bad drugs, and we can flood into the area and we'll have a good sense of the intelligence and what's going on. So as I said, it's deployment of first responders for fire, police, paramedics, health officials for an outbreak, so that we can actually cluster and surge around it. The benefits are, of course, emergency responses are faster. We can position ourselves when we start to see these outbreaks. Public health workers can reach persons in medical distress with the appropriate assistance, and police can actively respond to drug trafficking if they spot some individuals that they know. And once again, that's kind of what the app will send you in real time. And of course, you can set your smartphones up so they'll alert you when an application comes through and draw your attention to it. So in the city of Surrey, it's an older city, certainly not as old as New York. And we have a lot of our housing stock that's turning over. Charles was involved in an initiative on distressed properties. And the land values and the house values, land values in the last 2 years have gone up about 60%. So there's a lot of properties that are being held, and there's a lot of disinvestment taking place. And right now, if you're a criminal, if you go to the courts, and if you're, say, arrested for a property crime, which is probably on the lower level, you're probably, and you're probably pleading that you're a drug addict or you've got an issue with substance abuse, there will be individuals in the hallway that will be marketing their services to the Crown Council, Crown being and they will say that we have a place where we can take this individual and they can get support. And the support they get, the house, the recovery house, whether it's illicit or, well, I shouldn't say it's illicit, registered or not registered, but if it's a place for them to go, the judge is looking for that, and he doesn't want to incarcerate those people. So he'll place them in one of these recovery homes, and the recovery home operator will get $50 a day from the government. And they're either low or no barriers. And we have quite a number of them. We have about 84 of those in the city. Although most of them play a role for at least housing for these individuals, but they're no barrier. So there's some are privately run and some are unregistered. Some operate with few internal controls. And if you want to know where we plotted those, we started drawing this relationship to overdose deaths that cluster within 200 and 500 meters of recovery houses. And research is underway to look at the crime that's correlated with these properties, but certainly the overdoses and the deaths seem to correlate. So why did we pick 200 meters and 500 meters? The criminology theory will say that an individual who's drug addicted, and if they're foraging for their income, will likely be within those radiuses. That's the theory. So these people are semi-incarcerated in these places, but they have the ability to move around. So right now, we don't know what we don't know. But what we do know is the increase of 37% of the overdose rates from 2008 2016 to 2017 within 200 meters. And there was an increase of 50% of the OD rate between 2016 and 2017. So this has drawn some concern, and we also know that there's a large number of individuals that are overdosing in homes. So the death rates have increased from 17% from 2016 to 2017 and 43% in the 500-meter area between 2016 and 2017. So the results in cutting corners and taking risks in order to fill these houses with clients. Clients are often left to run the recovery homes by themselves. Clients use illicit drugs at recovery houses on the street or in the area, overdoses, and drug-related fatality clusters at near these places. Knowing the spatial distribution of the overdose deaths relative to the problem with recovery houses, we want to treat those with prevention. We want to make sure that individuals that are living in these homes have naloxone, they have support, and they have the opportunity to take, to assist them in another alternative, like Suboxone treatment or other things that won't kill them. We're concerned about the fentanyl that's being accessed. So basically, we'll look at prevention, policy regulation, and enforcement, and we want to make sure that these places are safe for them as well. So this will be a healthcare worker, a firefighter, paramedic, that will basically be approaching these places and working with these individuals to see if we can assist them. So the other thing that we're looking at is sewage epidemiology in the municipal wastewater system. And this is somewhat new. Mind you, it's been used in Europe for a number of years. And basically what we're doing is looking for an opportunity to look at the trends of opioid use, other illicit use, and evaluate the initiatives to curb drug consumption in our communities. Can we actually treat some of those neighborhoods? Wastewater testing offers a comprehensive and timely, cost-effective measure of figuring out what's going on in our neighborhoods. The studies that have been done in Ontario in 3 cities, we're actually able to calculate on a daily rate the dosage consumption per 1,000 population of the neighborhoods that we're serving the network. And at least it gives us some insight to figure out how big or small is the problem. So wastewater testing provides an efficient means for the greatest need for intervention programs if there's certain neighborhoods that are concentrated more or less. Wastewater analytics focuses on quantifying levels of drug metabolics, compounds excreted from urine after the body breaks down the processing. And the process measures concentrations of drugs actually ingested rather than those flushed down the toilet. So this is a sample, a demonstration of what was extracted from a couple of cities in Ontario, and you'll notice that there were the days of the week for the test site. There was 3 test sites that were looked at. Methamphetamine, NBA, cocaine, opiates, marijuana, all of those drugs can be detected in the wastewater. And that will help assist us in focusing on what our prevention interventions might be or might not be. That's the Metro Vancouver wastewater network. It's very complex, so you have to actually do the calculations of the populations that are serving the catchment areas and then extract those back on a daily basis. We've purchased automatic samplers that can be programmed, and it will take samples twice a day or once a day or once a day for 5 days in a row. Those samples are extracted, they're stored in a bottle or frozen, and they're sent to McGill University in Quebec, and the engineering department will analyze it. Stats Canada, well, this is basically the catchment of Surrey, and this project is conducted by Statistics Canada, and this is part of their project in order to help us understand the rate and the nature of the opioid crisis and what's going to happen. Oh, by the way, Canada is about to legalize marijuana, and that will happen in June, coming up this year. So we anticipate drug consumption will probably go up considerably if it's going to be anything like Colorado or Washington State. This will give us some insight onto what's going on, but our focus right now is the illicit opiates. We want to know where that's coming from. We want to know how big or how bad it is, and we need to know where the issue is. What do we do next? Because right now, frankly, we don't really completely understand the problem, and we need to get to that. So the other project that we're working on with Stats Canada is the mayor signed an agreement with them. It's a demonstration project in the city of Surrey. Federal government is supporting us, and we're going to be conducting an analysis on the social data linkage environment. And this is something that is relatively new for them. They've experimented with this in Saskatchewan, and they've looked at prolific offenders. They've looked at all of the characteristics of a prolific offender, and they're looking at how do they intervene, or can they get in front of the next crime? Can they find out what the social needs of that individual are to divert them into something that's different than the crime? And drugs are a large portion of that as well. So we're excited about that. They're well into the social data linkage and the programming in Saskatchewan, and they've offered to bring this to British Columbia, where the largest concentration of the opiate crisis is. So we're going to be focusing on that. We entered into an agreement with them in October. We're still extracting data from them. It kind of looks like this. The Royal Canadian Mounted Police are providing a history and context of all of the individuals who have died or overdosing multiple times. Surrey Fire Service and ambulance are extracting multiple overdose data for those individuals who are displaying that information. Fraser Health in terms of physician, pharmacy, and mental health data will all be in that social data linkage environment. BC Coroner for the deaths. We're wanting to focus on precision policy and programming and focus on the typology of the individual. And there's one typology I'm going to talk about next, after I talk about the safe point. So supervised consumption is something that I've heard that New York is considering. The city of Vancouver has had supervised consumption for over a decade in its downtown east side. So it's really hard to say what happened. It actually predates the fentanyl issue, and it's more about the overdose scenario. And they've had many overdoses that they've treated in there. Many people live in the area, and most of those are street-entrenched people. And it's a place for them to go safely, inject their drugs under supervision, and they claim, and I'm sure it's true, nobody's ever died in that scenario. We opened two actually on June the 8th and June the 20th in two locations in the city of Surrey, where our highly concentrated areas are of the street-entrenched individuals. Going back to the map that I mentioned to you, the kernel density area, the inset is where, on each end of that area is where safe injection sites have been established. The following images show 6-month period pre-illicit drug overdoses and post, and a 500-meter buffer. That's generally the area in which individuals seem to live and service that area, both at Safe Point and Cripple Creek facilities. So those are the two locations. Safe Point experienced a 42% reduction in overdoses occurring in a 500-meter area after the opening, and Cripple Creek saw a 17% decrease. So in terms of how does it line up, overdoses pre-517 at Safe Point, 301 afterwards in a 6-month period. Deaths were 8 before as opposed to 3. And Cripple Creek was 23 versus 19 and 4 deaths versus 1. So the other portion that we have discovered is WorkSafe, which is our workers' compensation organization within the province of British Columbia, responsible for assuring workers and seeing a greater number of injured workers that are struggling with the opiate dependency. We believe that this cohort, this large group of people that have been injured, were likely part of that scenario that I mentioned to you that were being prescribed opiates for pain management. And as a medical field started to become more and more concerned about it, started pulling back those prescriptions, and it created a vehicle or an opportunity for illicit drugs to make it way into the system. So Fraser Health, that population, greater Vancouver area, the region is about 2.8 million people. Fraser Health is about 1.8 million people. And they looked at men aged 19 to 59 who have been working in the building trades disproportionately have been victims of the opioid crisis. There are increased risk factors for building tradespersons such as exposure to transient workers, financial pressures, demographics. Fraser Health analyzed 45,000 visits for 5,000 people who were treated for an overdose in its emergency departments. They conducted a chart review of 90 men admitted to the hospital after serious or non-fatal overdose. This is what they found about them. They live with others and require support. Found by household member overdosing, nearly 75% were diagnosed with alcohol or substance use disorder. Higher rates of mental health, physical trauma, and pain were common. The most common industry they worked was in building trades. So the hypothesis here that we've just mapped out, we're mapping out the methodology, and we have a grant for this, and is to reverse engineer a worker's path into opiate abuse. And looking to work at his history, his clinical records, his prescription medication, and to create a profile. The work-safe individuals are actually responsible for those individuals to some degree. And if we can discover this relationship and in their charts and in their support from the work-safe mechanisms, perhaps we can locate them in the system and actually go back to them and actually support them. Offer them alternatives. Are you okay? Are you using illicit opiates? If so, we have alternatives for you. You don't need to be doing that. The healthcare system, I don't think is quickly, and certainly in British Columbia, openly admitting, if I can use those words, that we have been complicit in part of this problem in terms of prescribing and then basically not prescribing and not realizing that these individuals have become addicted. So once the harms are understood, it's possible to target workers that would have had opiate prescription, and can we get to them? Their healthcare records within the WorkSafe environment will actually indicate what they were prescribed. So some of this is our hypothesis, some of it is some hopes and dreams that we have for this initiative, but for sure this problem's not going away fast, and it's getting worse every day. So some of the stuff that we're doing here is theoretical, some of it's well entrenched and underway. I hope you find that this is useful for your situation, as bad or not bad as it is, but I've got a feeling that the market is really rich for fentanyl. It's a product that seems to be easily distributed, and once the individuals get it, there's a hunger for it, and I don't think it's going to go away soon. So with that, I thank you very much.
Thank you, Len. We have plenty of time for discussion and questions, but let me just seize on an opportunity to throw in another issue, which is, do you want to talk about just the development of Surrey and the proximity of this hotspot to basically Surrey's future development, and how it's this is to me, as an outsider coming in, could be perceived as something that threatens the very future of the entire community?
Well,
above and beyond the health and human impacts.
the fact that you know a little bit about the land use in the city of Surrey, where you see all of that sitting is exactly where the next 40 high-rises want to be. This is where the business development is expecting things to happen. Anywhere from the Legion towers for seniors and veterans to universities, which are basically growing up in the area, the Simon Fraser University and student housing. The businesses in the area, many have left because they can't survive. Their clients won't come, restaurants, for example, people just won't come to them any longer, and they've packed up and left. There's a real, a lot of pressure on the local government, the council, and the businesses that are putting on the situation. And of course, they're not very sympathetic to the situation or to the people. Fortunately, we are, and that's our job to be, and surely we are. But it's a very difficult environment because there's so much conflict going on.
A few minutes ago, you were talking about housing, getting these people
Right.
Over on A Street into housing, and the BC Supreme Court decision. I don't understand how getting them into housing will solve the opioid problem. It seems to me that even if they get into housing, they can continue taking the opioids.
It will not solve that. I think what we can hope for is each one of those, there's 3 workforce camps that should, or establishments that should be able to house all of the, say, 300 people that are on the street there that are opioid users or drug users. And the hope is it will include safe injection within that housing unit, and they'll be able to manage that situation. I don't think they're going to eliminate it. They're just simply going to manage it. The attempt is to manage it. And then for each individual, if we can convince them or transition them into a safer drug like Suboxone or something else, that's what the hope is. It's all about harm reduction. It's not about abstinence. They don't believe that's going to be successful. That's the strategy for today. And I'm not excited about success, to be honest with you. I think there's going to be a lot of tension that's going to occur because we're changing a lifestyle that people have enjoyed for several years on the street. And it's a social issue. It's all, everything that's there that's for them, we're going to split them apart. I'm not sure how that's going to go.
I didn't quite understand, with the safe injection program, who supplies the drugs? Is this stuff that the people, the addicts bring in?
They supply their own, yes.
They supply
They
their
bring
own?
their own, and it's under supervision, and there's a nurse there, a healthcare nurse that's there. And if they overdose, obviously she's equipped with the antidote.
What if they had a program where little by little the dose was reduced, smaller, very, very slowly, so the body wouldn't have that withdrawal?
The part that I think we're trying to get to is we're trying to provide them with an alternative, which was a safe drug, and with the safe injection. So right now they're bringing their own drugs, and if we can provide an alternative that we can convince them to do under medical care, like Suboxone or some other product, even pharmacy-grade heroin, something to that effect, and then we can manage that transition.
Wean them off of them.
Exactly. Well, there's some that don't believe we'll ever wean them off. We'll able to manage it. But this project with Stats Canada, if I go back to that for a minute, understanding the continuum. If I can take myself, for example, at 65 years old, and if I can find out where I went wrong at 14 or 16 or whatever the environment was, if we could develop, we need to be concerned about our young people that are coming through the system and what that trajectory was and how those people got there and what services or what things could we have done in order to divert that. That's my concern.
So I don't know much about naloxone, but can you talk a little bit about how you measure success? You know, is every time you give it, it's a successful intervention? Do you kind of track patients after they've been to the hospital, or is that something that you can kind of use as a metric to know how successful you are in that kind of administration?
Well, in the first sense, I can say that we're giving them a chance, another chance to live. And whether we carry them to the hospital or not is it's about 50-50, because most of the time when we wake them up, they'll bolt, right? They don't want to be part of that system. And we're giving them a chance. And the social workers and the healthcare workers will tell you that that experience can be a defining moment where you can have a conversation with somebody and potentially suggest to them that there's a better path because their life is about to end, right? And so there's no hard numbers for that, to be honest with you.
And I'm sorry, with people using it, is it that there are more users, or is it that it's become more deadly, or is it a little bit of both?
I think hypothetically, I would say the latter. I think it's become more deadly. I think we've had people that have been drug users for a long time, have been managing their lives, and something else has been introduced into the system that has manifested itself in an overdose. And they're using fentanyl, which is much more powerful, highly more addictive, and we're seeing this transition take place. I believe it's a little of both.
So Len, you mentioned the construction worker profile there,
Right.
9 visits. It seems like 9 visits for over the 5,000.
Right.
9 visits
90.
per person.
No. Yes,
Are those ER visits, or what are those? Just
they're ER visits.
and are they all drug related?
Yes, there were chart reviews that were done by Fraser Health, and they were linked them back to their drug use, and they were construction workers.
All right, so on average, they were visiting the ER 9 times for their drug problems.
Right.
Okay. And what you're trying to do is work backwards, try to figure out where can you intervene?
Where can we find those? I don't, well, maybe I'm a neophyte in the healthcare system. There might be some professionals here, but it just seems to me about 3 years ago, I went to a banquet at a golf course, and I woke up the next morning and I was really not feeling very well, and I only had 1 drink, so it wasn't that. And I got a call about 2 hours later. I didn't go into work, and the health authority called me and said, "You've been exposed to Norwa." So it seems to me that we're talking about a pretty deadly environment, and individuals that are in the research is telling us that this group is highly at risk. We will know if they've been prescribed an opiate or not, a painkiller. We should be able to very accurately figure out if this individual, whether they've displayed themselves into an ER or not, are likely at risk. And I think we have an obligation to try at least reach out to those individuals and say, "Are you okay? Is there something that we can help you with? Because if you're not, this is what's been going on." And so the health authority likes it, and they believe they have the authority to do that because of the crisis. So.
Hello, two questions about the naloxone response. And it's clear that the drug in itself is a temporary intervention, but
Right.
life-saving.
Right.
But you've also gone on to mention it representing potentially what in violent crime reduction we would call a teachable moment.
You're exactly right.
So I've got 2 questions, one about the drug itself and one about the potential for using it as a teachable moment. So first of all, the drug, how much does it cost? Who produces it? Just in terms of following the money in this situation.
Right.
And are there any challenges or alternatives that present themselves as a drug recovery?
So let me start with the teachable moment. So what we're doing is part of the overall provincial strategy is we've armed all of our first responders, whether it be paramedics, police officers, whomever, with information about alternative situations. You can dial 811 and you can get an addictions nurse on the phone, and somebody can get to you pretty quickly if necessary. So we've got that teachable moment, and we've heard that. I haven't seen it myself, and some of our guys initially were scoff at that, I have to be blunt, but certainly they're attuned to it today.
Yeah.
The next question was?
So that's really helpful, and around the teachable moment interventions, we have some through emergency rooms in London hospitals around violent crime.
Right.
And it's about getting somebody who's a good counsellor to that person when they're injured, at that point when they've come face to face with their own mortality.
Right.
But it strikes me that it's quite difficult because what we know, as you mentioned, people run off, and it's partly that physical response to coming around with an so people run away, don't they? So that must be quite difficult to create a moment, to create an environment.
Well, our first responders are becoming, and I think I mentioned this before, but they're becoming extremely stressed with their frustration of lack of, they're seeing it over and over and over and over again. And that's wearing on them considerably.
And the second question was really just practical. How much does a dose or 200 doses of it cost?
It's free to us. The healthcare system and the pharmacy, the government is just flooding it into whoever wants it, right? And so it's a half-hour course with an orange, for our first responders, and you can get it at the pharmacy. So I think it's under $10 a dose is what I've been told, but.
And any other products that are on the pharmacology market that do the same thing?
Not on
Do
the
something
horizon.
different?
Not on the horizon, but I am aware that some of the carfentanil, and this is anecdotal, but when they inject them once or twice and they're not coming around, they're getting really worried, and so it takes sometimes 4 or 5, I've heard, to knock off the receptors, and then that usually is a good indication that we have a strong amount in the system. And you had a question, sorry.
Yeah, I was interested in the wastewater as an indicator.
Yes.
Are you planning on using that in the aggregate to determine that in these high-intensity areas, whether or not you're targeting a reduction in wastewater?
Absolutely. That's one of the reasons why we're doing it. I mean, the problem is, first off, we don't know what we don't know. This will help us to get a little bit closer to knowing what we don't know. Mm-hmm. And the other part of it is if something happens, back to the point about, are we these teachable moments, are we actually having an effect? If we do, we might see indications, or we might see a barometer in the wastewater analysis, because we intend to do this over a long period of time to gauge and set a baseline and then be able to gauge against it. So, and we would be able to focus on potentially neighborhoods as well. If we see concentrations in certain neighborhoods greater than others, we can even get more granular on our wastewater devices. It basically is like a garbage can that fits down a manhole, automatically samples, so it's very easy to install, and we think it'll be very useful. I just have one short video.
You mentioned the wastewater. You mentioned that some parts of Europe have been doing this.
Yes.
They started it before you.
Yeah,
Where specifically?
If you send me a card, I'll send that to you. I'll actually send you the research papers as well. There's actually...
Can you send it to Professor Chang?
Yes, I can. There's several cities, and actually MIT is offering a service to do this, to actually go out and test your wastewater. And there's several cities that have actually signed up because they're trying to do what we're doing. They're trying to come up with more precision on understanding what the problem is, opposed to just kind of willy-nilly. Like, I hate to say this in this day and age, but we just don't know what we don't know because of the nature of it, right?
With every call, first responders fear it will cluster.
They're anxious, they're frustrated, and they're stressed.
A bad batch of drugs leading to a barrage of overdoses all around them.
It puts them on edge for the next cluster or the next call as to what am I going to be dealing with.
After facing 17 overdoses in just 72 hours, Surrey Fire decided to use technology to take matters into their own hands. creating a new tool to help deal with the opioid crisis.
The game changer is about the way of thinking and is trying to get in front of it.
Now, how this game changer works is by mapping emergency calls for overdoses in real time. Say you have one in this part of the city. A second one comes in just down the street. A third one nearby. And if a fourth one happens all within 1 square kilometer in a 4-hour period, that's considered a cluster. And first responders are notified right away.
That's going to help us in the moment to be able to determine where we need to send resources and where we need to focus some of our attention.
It can be the street entrenched in Abbotsford or suburbanites living in Delta. Overdose clusters do not discriminate.
We'll pilot test it in Surrey, then we can see if it works in other regions or if it can be adapted to other services.
Surrey Fire also partnering up with Statistics Canada, hoping the data will eventually point to more than just where, but also who and why.
We're hoping to be able to preempt that overdose entirely.
With Surrey Fire getting 10 alerts since July 2016, first responders more prepared to stop a cluster of overdoses from tearing the lives of so many apart. John Hua, Global News.
Well, that would be that. Thank you.